Welcome to this targeted revision deep dive.
Hey, everyone.
If you're listening to this, you are a resident deep in the trenches, prepping for your FRCS plastic surgery board exams. And our mission today is singular. No fluff, no wasted time.
None at all.
We are going to entirely master median nerve compression syndromes of the upper limb.
Which is, absolutely critical for the exams. They don't just want rote memorization.
Right.
They want your clinical reasoning.
Exactly. Before we dive into the anatomy, just some direct housekeeping. We know your time is valuable. Open your app right now and hit that follow button.
Yeah, do it now so you don't miss the next one.
And if you learned something valuable today, please rate the show. Also, I'm going to be completely direct here. You need to get a premium subscription.
You really do.
It is the only way to access the exclusive journal club and the clinical cases deep dives. You need that higher order reasoning for the boards.
It's the difference between passing and failing, honestly.
Yep. All right, so let's set the stage. I want to start with the foundational principles before we hit the specific anatomical pinch points.
Sounds good.
When a patient comes in complaining of tingling or weakness, we universally throw around the word compression.
Right, compression.
But at the microscopic level, what physical factors actually cause those symptoms?
Well, it's rarely just a physical pinch. We use compression as a catch-all term.
A simplified term, yeah.
Exactly. But the reality is multifaceted. Aside from just direct pressure squashing the nerve, you have three other major factors. The first is traction.
Traction meaning stretching.
Right, literally stretching the nerve beyond its resting length. And nerves have like a tiny bit of elasticity, but really not much.
And if it's stretched, it often leads into the second factor, right? Tethering.
Precisely. Tethering is when the nerve is restricted by surrounding tissue. So, scar tissue, an anomalous muscle belly, or a tight fascial band.
So it's literally pinned down.
Yes. And because it's pinned down, it can't glide normally.
So as the patient moves their arm, the nerve is subjected to excessive excursion.
Exactly. It's being dragged back and forth too harshly because it's caught on that snag. And that constant friction leads us to the final and arguably most critical factor.
Which is ischemia.
Ischemia, yeah. A tethered nerve suffers severely compromised microvascular blood flow. The tiny vessels supplying the nerve, the vasa nervum, they get choked off.
The nerve just starves.
It starves. The resting membrane potential alters, the axon misfires, and that's what drives the agonizing pain and the tingling.
Wow. So it's essentially a mechanical problem creating a vascular problem, which creates the neurological problem.
That is the exact way to frame it for the examiners.
Good to know. So what does this mean for etiology? Because examiners love asking for broad classifications of nerve compression.
Oh, they love lists.
Can you just rattle off the 9 broad categories for the listener?
Sure. You need to have these 9 locked in. They are anatomical, where nerves hit rigid pinch points. Postural, from dynamic movements like typing. Developmental, from congenital structures.
Okay. Inflammatory, like rheumatoid synovitis. Traumatic, from acute crush injuries or fractures. Post-surgical, so edema or hematoma. Metabolic, swellings like ganglia. And finally, iatrogenic.
Okay, wait, let's pause on metabolic.
Yeah, that's a big one.
It's a massive trap in the vivas. They dig into metabolic causes to test your systemic medical knowledge, not just your surgery skills.
Totally.
What specific conditions does the listener have to queue up if they get asked about metabolic causes?
If they ask for metabolic causes of carpal tunnel, you must immediately list diabetes, myxoedema.
Which is hypothyroidism, right?
Or Graves' disease, yeah. Also acromegaly and pregnancy.
And why do those matter so much?
Because all of them cause excessive water retention or soft tissue hypertrophy. In an inelastic space like the carpal tunnel, even a marginal increase in tissue volume spikes the interstitial pressure.
Leading right back to that ischemic cascade.
Exactly. It's a volume mismatch problem.
Fantastic. All right, let's do a quick anatomy check. You cannot walk into the FRCS without knowing the origins of the median nerve cold. Absolutely not. You have to know it's formed by the lateral and medial cords of the brachial plexus.
And it contains fibers from all roots.
All of them. C5, C6, C7, C8, and T1.
C5 to T1. Lock that in, guys. Okay, moving to the most distal part of the upper limb. Carpal tunnel syndrome.
The most common one.
Yeah, affecting 10% of the population. Heavy female preponderance, usually peaking between 45 and 60 years old.
The carpal tunnel is, it's the ultimate study in anatomical vulnerability. It's an entirely inelastic fibroosseous tunnel.
I always picture it like a rigid, hard-shell suitcase that's already packed to the brim.
That's a great analogy.
You've got the 9 flexor tendons packed inside. The median nerve is a fragile souvenir right on top, and the transverse carpal ligament is the heavy zipper.
Yeah, pulling it all shut.
And if the tendons swell even a fraction, that nerve gets crushed against the zipper.
Exactly.
For the exam, they want specifics. What exactly forms the suitcase, and what are the 4 precise attachment points of that transverse carpal ligament?
Okay, so the base of the tunnel is the concave bony carpal arch, bridged over the top by the transverse carpal ligament.
Also known as the flexor retinaculum.
Right. The 4 bony attachments you must know are, on the radial side, the scaphoid tubercle and the ridge of the trapezium.
Scaphoid tubercle, trapezium ridge. Got it. And the ulnar side.
Hook of Hamate and the pisiform.
Okay. Now, as surgeons, we don't have X-ray vision. How do we localize the deep structures before we cut, using Kaplan's cardinal line?
So Kaplan's line is your classic surface guide. For the exam, it starts from the apex of the first web space, drawn straight across the palm to the hook of Hamate.
Running parallel to the proximal palmar crease, right?
Yes, exactly.
And what are the critical intersections on that line?
There are 2 main ones. First, where Kaplan's line intersects with a vertical line down for the radial border of the middle finger. That point localizes the recurrent motor branch of the median nerve.
Okay, middle finger radial border is the motor branch.
Yeah. And the second is where it intersects with a line from the radial border of the ring finger. That marks the superficial palmar arch and roughly the distal margin of the transverse carpal ligament.
Now, I want to jump in here with a quick clinical reality check. Recent anatomical studies in our source material show that these surface markings are only approximate.
Oh, absolutely.
So do not treat them as gospel in the theater. A millimeter of variation changes everything.
They're a rough guide, not a GPS. Which brings us to the variations of the recurrent motor branch. This is arguably the most dangerous part of a carpal tunnel release.
The Lanz classification. Let's explain why this matters. The median nerve is the main highway, and the motor branch is the exit ramp to the thenar muscles. Break down the Lanz classification.
You need this for the Viva. The most common exit route, about 46% of cases, is the extraligamentous pattern.
Extraligamentous.
Right, where the motor branch divides strictly distal to the flexor retinaculum. It takes the standard exit well after the tunnel ends.
Which is the safest route because it's out of the way of your scissors.
Usually, yes. Then, in 31% of cases, you have the subligamentous pattern.
Subligamentous, okay.
The branch divides early, beneath the ligament, and travels along the floor of the tunnel. But the absolute most treacherous variant is the transligamentous pattern.
Oh, that's the scary one.
Yeah, seen in roughly 23% of cases. The motor branch literally pierces directly upward through the thick tissue of the transverse carpal ligament itself.
Nearly a quarter of your patients will have that. I mean, if you're passing scissors under the ligament to divide it, and that nerve is threading right through the middle.
Your visual field is obscured.
Yeah, you blind snip and you transect the motor branch. The patient wakes up unable to oppose their thumb.
Which is exactly why we emphasize open, visualized releases.
Completely. All right, let's bridge this anatomy to the clinical OSCEs. Say a patient presents with classic carpal tunnel.
Numbness, dropping things, night waking.
Classic exam question, though. You test sensation, and the palm of their hand is completely normal. Why is the palm usually spared from numbness?
This tests your knowledge of the palmar cutaneous branch of the median nerve.
Right.
This small sensory branch splits off proximal to the rest, usually 1 to 5 centimeters proximal, and it pierces the deep endobrachial fascia, entering the palm superficial to the flexor retinaculum.
So it jumps off the highway early and takes the overpass.
Exactly. Because it travels over the roof rather than inside the packed suitcase, it doesn't get squashed. The palm retains normal sensation.
Beautiful. Now, provocative testing. Standard Phelan's test is flexing the wrists at 90 degrees to squeeze the tunnel, right?
Right.
But what if they can't do it? When do you use reverse Phelan's versus Durkin's sign?
You use reverse Phelan's when conventional Phelan's fails or they have limited flexion. You have them maximally extend their wrists instead.
How does that work mechanically?
Extreme extension drives the proximal lumbricals down into the carpal tunnel, instantly raising the pressure.
Ah, okay. And Durkin's sign?
Durkin's, or the carpal compression test, is vital for patients with severe arthritis who can't flex or extend at all. You just use your thumbs to apply direct, sustained pressure over the ligament.
Manually recreating the crush.
Exactly.
Okay, so you suspect carpal tunnel, you order nerve conduction studies, the results come back totally normal. As a surgeon, my instinct is to say, there's no compression. Can we rule it out and send them home?
Emphatically no.
Really?
This is where examiners see if you're a clinician or just someone who reads test results. Normal studies do not rule out compression
I know it.
because early carpal tunnel is often dynamic. The nerve might only be compressed at night when the wrist falls into flexion. But sitting upright in a warm lab at 2 p.m., the microvascular flow is fine.
So the clinical diagnosis is paramount.
Always.
But if the studies are positive, what is the single most sensitive finding?
Prolonged distal motor latencies. It just takes longer for the signal to cross the compressed segment.
Okay, moving to management. A patient wants a steroid injection. What's the actual success rate?
It's often a temporary bridge. You quote them an 80% initial relief rate. The steroid rapidly shrinks the swollen tenosynovium.
But only 20% are asymptomatic at 1 year, right?
Yes, because you haven't fixed the structural volume mismatch. Once the steroid wears off, it gets crushed again.
So they need surgery. Let's talk complications. A patient comes back post-op. Nighttime tingling is gone, but they complain of severe aching pain over the base of their thumb and pinky.
The thenar and hypothenar eminences.
Yeah. What is this, and how do you explain the biomechanics to the examiner?
That is called pillar pain. Extremely common early post-op. It resolves over 6 to 12 months.
And physiologically?
It's likely due to the altered geometry of the carpus. The transverse carpal ligament is a strong tie rod holding the carpal arch together. You cut the tie rod, the arch subtly widens and flattens out.
Changing the wrist mechanics entirely.
Right. That shifting plus inflammation at the cut edges of the ligament causes significant pain when gripping.
Brilliant. Okay, completely different diagnostic puzzle. Patient has clumsiness, but they do have altered sensation in their palm. And 0 night waking.
If the palm is numb, the palmar cutaneous branch is involved.
Which means the compression is happening before that branch splits off. We have to look further up the arm. Pronator syndrome.
Exactly. Proximal compression in the forearm. It's uncommon, but frequently mistaken for carpal tunnel.
And nerve conduction studies here are almost always normal, right?
Almost always, because the compression is tied to dynamic movements, not a static bony tunnel.
Okay, listener, pure anatomy time. There are 4 specific anatomical pinch points for pronator syndrome. We use resisted movements to trigger each one, break down the 4 sites, and the tests.
Site 1 is the lacertus fibrosus, or bicipital aponeurosis, a fascial band off the biceps tendon. You test it by resisting elbow flexion and forearm supination.
Resisted elbow flexion and supination. Got it.
Site 2 is the 2 heads of the pronator tears itself. The nerve passes between them. You test this by resisting forearm pronation with the elbow completely extended.
Extended elbow, resisted pronation. Okay, site 3.
Under the fibrous arch of the FDS, the flexor digitorum superficialis. Test this with resisted flexion of the middle finger PIPJ.
And site 4.
The rare one. Beneath the ligament of Struthers, an anomalous band from the humerus down to the medial epicondyle.
Okay, memorize those triggers. But here's an exam curveball. We said Phelan's test is for carpal tunnel at the wrist. Why is Phelan's paradoxically positive in up to 50% of pronator syndrome cases?
It seems counterintuitive until you understand the double crush phenomenon.
Break that down.
A nerve is a living tube. Nutrients and proteins transport down the axon from the spinal cord to the fingertips. That's axoplasmic flow.
Okay.
If the nerve is compressed proximally, say at the elbow, it impairs that flow.
It creates a bottleneck.
Yes. The entire nerve distal to that point becomes starved and wildly hyperirritable. So it becomes exquisitely sensitive to minor compression further down, like simple wrist flexion during Phelan's.
Supply chain issue. The traffic jam at the elbow makes the road further down malfunction.
Exactly. One proximal crush sets up the vulnerability for a second minor crush to trigger massive symptoms.
Incredible. All right, let's look at purely motor syndromes. Patient has weakness, but absolutely no numbness. Anterior interosseous syndrome, or AIN.
The anterior interosseous nerve branches off the median nerve deep in the forearm. Purely motor, no sensory fibers to the skin.
And it innervates 3 specific deep muscles, right?
Yes. The flexor pollicis longus, FPL, flexing the thumb tip. The lateral half of the flexor digitorum profundus, FDP, for the index and middle fingers. And the pronator quadratus.
So how do we quickly test AIN on the ward?
Test the FPL and index FDP simultaneously by asking the patient to make the O sign, touching the tips of their thumb and index finger to make a perfect circle.
But they can't do it.
Right, they've lost the terminal flexors, so the pinch collapses into a flat pad-to-pad posture.
Like pinching a piece of paper. And how do you test the pronator quadratus?
Check for weakness of forearm pronation. But the trick is, You must test pronation with the elbow fully flexed tightly against their side.
Why flexed?
Flexing the elbow mechanically disadvantages the powerful pronator teres at the elbow. It isolates the weaker pronator quadratus at the wrist.
Phenomenal clinical pearl right there. Flex the elbow to isolate it. Now, examiner pushback time. If AIN is purely motor, why do these patients complain of a deep aching pain in their forearm?
Classic trap. Even pure motor nerves carry afferent sensory information back from the muscles and joints. It doesn't supply the skin, but it supplies deep proprioception and pain.
So when it's compressed, often by fibrotic bands in the pronator teres or Ganser's muscle,
The anomalous accessory head of the FTL, yeah.
that deep afferent pain signal is very real.
It is entirely real.
So what's the timeline for conservative management? How long do we splint and wait before operating?
Strictly 6 to 12 weeks of conservative treatment first. Splinting, observation, spontaneous resolution is highly likely.
But if there's no improvement after 12 weeks,
Then you move to surgical decompression. But warn the patient that neurological recovery from proximal compressions is very slow.
all right, look at the time. We've blitzed through ischemic mechanisms, the carpal tunnel suitcase, Lands classifications, double crush, and AIM biomechanics. To wrap up, I want to leave you, the listener, with a provocative thought.
Let's circle back to the 9 classifications of nerve compression.
Yeah. We talked about anatomical and metabolic, but think deeply about the iatrogenic causes. Picture a Viva scenario. Patient undergoes a 6-hour abdominal procedure under general anesthesia. They wake up with a profound median nerve palsy, hand entirely numb.
An incredibly insidious cause.
Consider how you'd identify and manage an iatrogenic compression caused purely by improper armboard positioning and unnatural stretching on the operating table.
The patient is chemically paralyzed, asleep, and can't protect their own joints or tell you about ischemic tingling.
It tests your situational awareness, traction injuries, and operative protocols. Think about how you would defend your own positioning protocols in a high-pressure Viva.
Definitely something to mull over.
All right, that's our time for this deep dive. Drop a comment or a question about today's revision topic below. What concept finally clicked for you?
We read all your comments. It helps us tailor the next sessions.
And a final reminder, press follow on your app right now. Rate the show if it helped clarify your prep. And most importantly, do not forget to get that premium subscription.
Unlock the Journal Club and clinical cases.
You need that clinical reasoning, and they are waiting for you. Keep studying hard, trust your prep, understand the why behind the what, and we will see you on the next one.